I want to start with, I've created a list. I'm not like, you know, when people get up and they accept their awards, they read off things. I've been making notes all day, and there's a few things that I want to mention. Matt mentioned that 100% or something roughly of people that were invited to this meeting decided to attend and come give talks. I think that speaks volumes to the fact that we recognize a need to be doing this sort of stuff and to be exchanging ideas like this. So I just think that's important. Also, these meetings are important for me because every time I leave these meetings, I have new mentors coming out the back door. So while you don't know that it's you yet, you will probably by tomorrow. I also like this meeting because I get hugs in addition to handshakes, which means I'm really in the right room, which is great. And yeah, that's it. Okay, so thanks to Matt for organizing a fun meeting. This story goes all the way back to Kansas, where I realized that in fact I had no technical skills surgically, but I could do this, which was take diet out of a box and put it on the top of a cage. And that was literally, I was like, oh, great, we could study diet-induced stuff because I can do that. And we ended up getting into fatty liver disease. And when one matriculates at Kansas, you, to some extent, almost have no choice but to think about methionine, choline-deficient diets and high-fat diets and NASH. So we got into this, and I took a stab at this, and I guessed that Bert would do a better job of talking about arsenic than I would. So I kind of changed the elements of my talk, and I'm going to be very vague. We're going to have two parts. We're going to talk about how the coagulation cascade may participate in fatty liver disease, at least in experimental systems. And then I'm going to go on, and it's going to be kind of a soapbox type few slides where I might try to convince you that maybe for your environmental exposure, your drug of interest, this same pathway may be at work. So for those of you that don't know me or know the lab, I just want to give you a quick orientation because while I'm going to talk about fatty liver today, we have a lot of interests, and we've heard a lot about a lot of these things today in the audience. So we have an interest at the intersection of liver injury and liver disease and blood coagulation. So we have programs in acute acetaminophen-induced liver injury and regeneration, fibrosis, cholestasis, fatty liver disease, probably too many things. And within the scope of liver injury and disease, we're interested in all things hemostasis. We're interested in excess clotting and bleeding, but also how subtle changes in these factors that we think of when we watch Game of Thrones and someone gets stabbed in the stomach with a sword. Well, that's a very robust activation of clotting. Here, these more subtle changes may drive disease. And at least personally, I feel that there's high value in learning mechanisms and thinking about, looking under new lampposts in this intersection, because coagulation changes are essentially inseparable from acute liver toxicity as well as chronic liver diseases. Moreover, this kind of stuff was thought about in the 30s if one goes back to the literature, but coagulation proteases and their targets are increasingly appreciated as modifiers of liver disease. Also, elements of the coagulation cascade have emerged as potential biomarkers of liver-related morbidity and mortality. And as crazy as this sounds, it may very well be a therapeutic target. There's actually some clinical evidence to suggest that this is a possibility. So I dug this old slide out. This was something that I presented back in 2011, and I think it still applies here. We kind of look at NAFLD and NASH as being within this window of obesity and metabolic syndrome. And for the most part, this has been presented several times today. We know that part of the transition from a normal liver to NAFLD, in particular NASH, involves an inflammatory response. And associated with that is certainly a connection to perturbations in coagulation, either activation of the coagulation cascade or fundamental changes in the expression of coagulation factors by the liver. And we're certainly interested in this. So don't take the next arrow to mean we're not interested in this, but what really hadn't been explored is whether this was actually a cycle of doom, and that was that these coagulation changes actually came back and had the capacity to drive or exacerbate the disease. So I want to orient everybody to the blood coagulation cascade. I'm grateful to Dr. Artiel for actually introducing this earlier in the day. It saves me some time when I present this, which is great. Nowadays, this is actually a little bit dated. For those of you who learned about clotting even 10, 20 years ago, this has changed quite a bit. So I sort of need to update this one, but this is a simplified diagram of the coagulation cascade, but I just want to orient you to a few arms. You have really a procoagulant series of serine proteases that ultimately lead to a protease called thrombin. Thrombin is kind of the pinnacle, leading edge protease of coagulation that has a whole bunch of targets, including soluble fibrinogen. And you've heard about this protein fibrin that gets deposited in the liver. Thrombin coordinates the deposition of fibrin. This can lead to the formation of what we think of as a blood clot. Now, this pathway is initiated by a protein called tissue factor. Yeah, whenever I go to SOT, people always ask me, what factor in tissue do you think it is that's activating coagulation? That's tissue factor. Its other name is coagulation factor 3 or thromboplastin. So tissue factor is actually a cellular receptor for factor 7A, and the formation of that complex kind of basically pulls the trigger on clotting, and you initiate this cascade. Of importance, there's a balancing act here. We have anticoagulant factors that at a number of positions aim to attenuate or shut this process down. And also of importance, we have a fibrinolytic arm down here, which is also self-regulating, that's designed to break down blood clots. So it's important that this system stays in balance. Today, just for the moving parts that we're going to talk about, we're certainly going to talk about tissue factor a little bit, we're going to talk about thrombin, and we're going to talk about something that's not on this picture called protease-activated receptors. So when one looks at NAFLD and NASH, and this has been an evolving literature over the last several years. In fact, when I first started thinking about this project, I was encouraged by our external advisory committee at Kansas to not actually pursue these studies. And that was because at the time, the concept what remained, and amongst some crowds, it was just at gastroenterology in Michigan, and even there, they mentioned this, we're still trying to convince people that this chronic liver disease isn't just a disease of bleeding. It's a disease of bleeding and clotting, and it's this tenuous balance, and you can go one way or the other. But it's becoming increasingly, I think, apparent that in patients with NAFLD and NASH, even in early disease, that there's a procoagulant imbalance. And that may be because of a defect in anticoagulant factors. It may also be because of a modest but excess activation of coagulation. And one can see that there's both biomarkers in the blood of increased coagulation as well as potential genetic susceptibility. Even blood proteomic type studies have identified elevations in prothrombin fragments with the progression of disease. We've also identified, just very simply, in patients, these are liver biopsies of both pediatric and adult NASH, there's elevated fibrin in the levels of these livers, so suggesting there's an increase in thrombin activity and fibrin deposition in patients. In addition, and we model this in multiple different ways in the lab, and I think we're continuing to try to humble ourselves in what our experimental settings can tell us and add diversity, but also understand the models we're using. I think it was Dr. McLean this morning that said, you really need to know what's in your diet. And I think we really need to be doing a better job of that. We say high-fat diet. Well, what fat? How high is it? So that's something we're thinking about. But just to orient you to this slide, on the y-axis up here, what you're looking at is plasma thrombin, antithrombin. This is an indicator of thrombin generation that's lasting enough in the plasma where we can detect it. And what we've done here is we've fed mice either a control diet, which is just a purified chow A93M, or a high-fat diet, and here it's 40% from butter. So yeah, it sounds fantastic, a Krispy Kreme. Anyway, so by the time you get out to 3 months here, what you can tell is there's a significant increase in plasma thrombin, antithrombin. And if you then jump one graph down, you can see that that connects to an increase in serum ALT activity. So temporally, there seems to be a connection between an increase in hepatocyte injury as well as coagulation cascade activation. On the right, you're actually looking at a fibrin stain, counterstained with hematoxylin. In mice-fed control diet, you'll see a little bit of fibrin, and oftentimes it's associated with the intima of larger vessels. That particular clotting probably occurs post-mortem, and we can talk about why that is. But what you can also see is associated with the development of hepatic steatosis over time in mice, there's certainly deposition of fibrin. Where it's localized tends to be in the hepatic sinusoids, but we do see it occasionally periportal, wrapped around bile ducts and cool stuff like that. But just for proof of principle, there's absolutely coagulation cascade activation in the mouse model, like in patients with NAFLD and NASH, and there's also hepatic fibrin. So collectively, and I'm just giving you a sampler here, there's strong evidence to indicate that NAFLD-NASH in both experimental settings and patients is associated with a procoagulant state. So our long-term goal, and we set out on this really back in 2008 or 2009, getting started, was to kind of determine the role of coagulation factors in the pathogenesis of NAFLD-NASH in experimental settings. I have clinical on here because we're consistently looking for partners in that. And we really want to be able to connect what we're doing in our models or experimental settings to what's happening in humans. So where we started out was actually kind of going back to the thing that pulls the trigger in clotting. We wanted to know what the role of tissue factor was in fatty liver disease. So just to give you an idea of what tissue factor is, it's coined a hemostatic envelope. And this has to do with where tissue factor is expressed if you go to a textbook and you think about what this protein needs to do. And that is, it's actually expressed by cells that are away from blood. This is a cellular receptor for 7A that floats around in your plasma. When it contacts tissue factor, you activate clotting. So the best way to prevent that is to keep it separated. But in the event of endothelial injury, 7A can contact tissue factor, and through a reaction that involves platelets, subendothelial matrix, et cetera, matrix will be important, very important, Dr. Artiel, I'm excited. So we can preserve hemostasis. Now this is good. We want to have a clot in the right place to prevent leakage and hemorrhage outside of this blood vessel. The problem exists when tissue factor is expressed, perhaps not in the wrong place, but certainly in contact with blood. And that can set off clotting that may or may not be pathologic. So here's tissue factor in a membrane, and this is my new scheme of coagulation, so you can forget about the rest of this stuff. So tissue factor, through a whole bunch of stuff, yields thrombin, which is this serine protease. So in a series of studies, some of which were in collaboration with Nigel Mackman, who's now at UNC Chapel Hill, we were able to demonstrate that compared to mice fed a control diet, and now we're looking out at 3 months, both in mice fed this Western diet as well as the methionine choline deficient diet model of NASH. And we're applying multiple models. This is one. Okay? There's a significant increase in thrombin, antithrombin. So the question was, what is the impact of tissue factor deficiency on thrombin generation in these experimental settings? And here's just a sampler of the data. So on the left, what you have is actually, oh, I should go back and tell you, because I'm not going to talk about that. If you take away tissue factor, thrombin goes away. There's no more pathologic thrombin generation. And that shouldn't surprise you because it's kind of the key trigger. We can talk about intrinsic pathway for those that are interested. But what's the effect on liver pathology? Here you have serum ALT activity in mice that are fed a control diet or a methionine choline deficient diet. This study, I think, was only a 2-week feeding. And for those of you that have done this model will tell me that that's incredibly short, and you'd be right. And we'd really like to expand that to go on to look at other times fibrosis. But what you can see here is that compared to what we call control mice, we'll call them, they're basically express about 50% of normal, actually about 80% of normal tissue factor levels. Compared to mice that are called low tissue factor mice, these express about 1% of normal tissue factor levels. You can't get a tissue factor knockout, but you can get a low tissue factor. What you can see is that tissue factor deficiency significantly reduces serum ALT activity, suggesting that tissue factor-driven coagulation contributes to hepatic injury in this setting. Even more fun was a completely different study, and now we're looking at a different model where LDL receptor deficient mice fed a high-fat diet. So now we're looking at a model of hypercholesterolemia as well as obesity. And they do get athero if you push them hard enough. We're actually subjected to bone marrow transplantation. So these mice have either wild-type bone marrow or tissue factor deficient bone marrow, where all non-hematopoietic cells express tissue factor. And here you're looking at oil red O after these mice were fed a high-fat diet for 3 months. And what you can see is plenty of red, plenty of lipid in mice that had wild-type bone marrow. But in the mice that lacked tissue factor on hematopoietic cells, there's an enormous reduction in hepatic lipid accumulation in these mice. And this is actually connected with the observation that it's probably monocytes that are the cellular source of tissue factor in this scenario. So you actually have hematopoietic cells driving liver disease, which is really neat. So coming back to coagulation, if tissue factor is required for thrombin generation, what's the role of thrombin in this whole process? So we asked that question. We did that using some pharmacological tools that were available, and I can talk about genetic strategies as well. We're pretty darn sure of these results, but we took 2 strategies. We utilized argatroban, which is kind of a weaker thrombin inhibitor and also has limited clinical utility. It's still used to treat HIT and things like that, but we also used dabigatran, which is also an FDA-approved orally bioavailable direct thrombin inhibitor. And we did this in 2 strategies. In the first study, we were following up on the bone marrow transplant study. We took LDLR deficient mice, fed them a high-fat diet for 16 weeks. But in the last 4 weeks, we actually administered argatroban, and this was done via a subcutaneously implanted microosmotic pump. So this was kind of a therapeutic intervention. Generally, people don't go in and say, I'm thinking about getting fatty liver disease. Is there a drug that I can take to prevent that? Usually, they're coming in with the disease and are looking for a treatment, so we thought we could do that. But at the same time, we've also explored prophylactically the impact of dabigatran, this new, or you've seen this on TV as Pradaxa, this new orally bioavailable thrombin inhibitor, and we did that in wild-type mice. So I'm going to breeze through this data and actually just kind of get to the take-home message. When we administered argatroban to LDLR receptor deficient mice that have hepatic steatosis, they also seem to have more inflammation than wild-type mice, and this has been published as well before. Remember, this is only a 4-week inhibition of thrombin. There wasn't an enormous effect on steatosis at that time, But there was actually a rather dramatic reduction in the activation of stellate cells within that 4 weeks, as indicated by alpha smooth muscle actin. There was also a reduction in plasma MCP1. We've heard about that as a key mediator of NAFLD from serum. And then also, remarkably, there's a significant reduction in serum triglycerides and cholesterol within 4 weeks. Now, I still think this is crazy, all right? But the data were the data, and this was kind of compelling. So when we went in to look at what dabigatran would do when we exposed the mice, and this is from feeding high-fat diet, we're looking at fibrin. Here you can see there's a reduction in fibrin in red in mice given dabigatran, but there's also a serious prevention of hepatic steatosis in those animals as well. That's connected with a reduction in serum ALT activity as well as a reduction in hepatic inflammation. And here this was just a quantification of hepatic inflammatory foci. We've also looked at macrophage accumulation and whatnot. And like the LDLRs, although these guys aren't incredibly hypercholesterolemic, there's a significant reduction in serum cholesterol as well as hepatic expression of MCP1. So those data combined with the tissue factor data sort of set up a scenario where tissue factor-driven thrombin generation is modifying fatty liver disease pathogenesis. Now, how can that possibly be the case? And we're at a juncture now where we're beginning to consider how different thrombin targets could participate in this process. And one of them is protease-activated receptors. And one of the thrombin receptors we're interested in is called PAR1. This is perhaps the most well-studied thrombin receptor. These are really cool for people that haven't seen these yet. These are tethered ligand G protein coupled receptors. So how can a protease, a molecular scissors, talk to a cell? Well, PAR1, what it does is just kind of waves this tethered ligand outside the cell, and thrombin goes over and clips that ligand, and the remaining peptide folds over and acts as basically a bound ligand for that G protein coupled receptor. So in principle, for example, this is how thrombin can activate platelets, but it also raises an important point that our biology doesn't let clotting occur in a vacuum, and this is a way of thrombin and other coag proteases talking to neighboring cells and communicating to them. So we wanted to investigate whether PAR1 was potentially involved, and to do that we have lots of tools. We probably have too many tools in the lab, but we utilized PAR1 deficient mice. One species note, mice don't have PAR1 on their platelets like humans do, so this can't be a platelet effect, just something to think about. But when we look at both H&E stained livers as well as oil red O, I think it's pretty easy to appreciate that PAR1 deficient mice have a significant reduction in steatosis. I can try to point over here for you guys as well, but sorry about that. You're probably facing the other way the whole time. I'm sorry. So PAR1 null mice also had a significant reduction in triglycerides when we pulled those out, extracted them, and measured them as well. And while I don't have it on here, I kind of forgot to throw it on there. PAR1 null mice also have a reduced serum ALT in the methionine choline deficient diet model as well. So it looks like PAR1 is involved. So this is kind of where we're at. We have really literature evidence that clinical and experimental NAFLD-NASH is associated with coag activation, and it looks like tissue factor, generation of thrombin, which activates PAR1, all collectively contribute to the pathogenesis of this disease in an experimental setting, in mice, in a couple different models. Where we're going with that is really defining kind of the cell-specific role of PAR1 in this whole process. So PAR1 is probably expressed by every cell type in the liver. It'll only take time to figure that out. There's not definitive evidence for hepatocytes yet, but it's certainly on endothelial cells, Kupffer cells, stellate cells, and bile duct epithelial cells. So we actually think that it's driving metabolic inflammation in the liver, and we're working on that. We'd also like to try to figure out how thrombin substrate specificity may impact disease. So thrombin can have both procoagulant targets, like making clots, but it also turns around and shuts down coagulation through some of those anticoagulant pathways. So we have some tricks that we're going to try to pull to study that. And we're kind of keen on seeing if any of the new novel oral anticoagulant drugs via antithrombins or anti-10As, how those actually impact established NASH and fibrosis. Oh, that's right, I'm switching gears. Okay, so the question is, could environmental exposures exacerbate thrombin-driven fatty liver disease? This is very generic, very speculative, but I'll show you some stuff, and seriously, my goal is maybe you'll walk away saying, God, you know, maybe we should look at tissue factor activity, or we should look at thrombin generation. I mean, if we're going to drive some collaboration, that would be pretty cool. So are there procoagulant environmental exposures? And let me just pose a scenario, and I'm going to do this because I don't want to disenfranchise you guys. So coagulation is intimately tied with inflammation. So where if one has, for example, an inflammatory response that drives cellular injury, activation of platelets, or increases the expression of tissue factor, This can ultimately drive a procoagulant response that may contribute to thrombosis. At the same time, coagulation can contribute to inflammation through activation of these protease-activated receptors, fibrinogen-driven processes, as well as platelets. And this is certainly associated with obesity-associated pathologies. So if you have a chemical that hits anything on this vicious cycle, you have the potential to impact coagulation, which may very well be an inducible amplifier. So one simple possibility where this could occur is at the level of the monocyte in high-fat diet, which seems to be generating the thrombin. If you have a xenobiotic exposure that ever so slightly tickles tissue factor expression by these cells, you have the potential to increase thrombin generation. Under ideal conditions, 1 molecule of tissue factor can generate 10,000 of thrombin. So subtle changes are important. So in just some fun kind of actually preliminary studies, and I would argue they still remain preliminary, we could really use some help to take this to the next level. We took human PBMCs that were primary and exposed them to arsenic as sodium arsenide in vitro. This is a 30-minute pretreatment, and then stimulated the cells with LPS and looked at tissue factor activity. And we can talk about how we do that another time, but trust me, we're measuring tissue factor activity in this case. And we see a robust increase with LPS that was further enhanced by arsenic, although those levels of arsenic had no effect on their own. So what's clear under conditions of high-fat diet, and probably in mice, monkeys, and humans, is that both endotoxin as well as oxidized LDL can activate Toll-4 signaling. So while we've utilized LPS here, it may be another agonist, and that this drives thrombin generation. So we went and we looked in mice that had been exposed to arsenic in a high-fat diet utilizing the model that Dr. Artiel had developed, and found that when we looked at blood cell mRNA levels of tissue factor, there was actually a significant enhancement of TF expression by blood cells in arsenic-exposed mice fed a high-fat diet. Moreover, this was connected with increased thrombin generation in this model, suggesting that that arsenic exposure is procoagulant. And I've also managed to pull some data from Dr. Artiel's paper. This could very well contribute to the enhanced deposition of fibrin in the livers of these mice and the increase in ALT based on our genetic studies looking at tissue factor deficiency. Other environmental exposures, I don't think we're talking about this at this meeting, but there's increasing evidence that particulate exposure can modify NASH. This stuff's highly procoagulant, crazy procoagulant. So this may be a connection worth exploring. The other thing that's incredibly interesting is that we may have the effect of compounds actually directly modifying tissue factor activity. For example, TF activity above and beyond expression is regulated by oxidized thiols. So if arsenic is working like that, that could be pretty cool. But also even going back to actually 1980, cadmium is certainly associated with increasing tissue factor procoagulant activity so much that it's utilized as a tool in vitro to study tissue factor activity. Mercuric chloride, same thing. What about further downstream from thrombin? Could we have exposures that modify PAR1 expression or activity? And being at Michigan State, Tim, are you awake? Cool, okay, perfect. So being at Michigan State University, you get an opportunity to learn about dioxin, okay? And I'm no expert on this, but the Zakharewski lab is. And I happen to be on the same floor with them, and I said, hey, do any of these things change? I gave them a list, and they said, well, this F2R goes up. I'm like, wow, that's the thrombin receptor PAR1. That's really cool. So this is in TCDD-treated mice. And given the fact that we have these fun tools, we went ahead and took a model that Dr. Zakharewski will talk about tomorrow morning and examined the effect of PAR1 deficiency. And remember, this is highly preliminary, but fun. And that is what we found in mice treated with TCDD. There was a significant increase in ALT, and this was reduced in mice lacking the thrombin receptor. And moreover, and this was published in Toxide recently by another group in France, chronic exposure to TCDD causes liver fibrosis. This is serious red here. And this was reduced in PAR1 null mice. I don't know where this story will go, but it continues to connect coag and signaling processes to chemically induced liver injury and disease. So if I have you take away anything, and I'm sure my time is up, coagulation is central to NAFLD-NASH pathogenesis. Please don't think of it only as a consequence. It's probably modifying disease, and we are seeking clinical partners to help us ask those questions in more detail. Moreover, don't forget that environmental exposures have a strong potential to tickle this pathway. So this may be one additional mechanism into the ones that you're already pursuing that could modify this disease process. So this is the gang with the corpse flower that opened up at MSU recently. A lot of the high-fat diet work in the lab has been done by my postdoc, Anya Kopech, but we're really kind of a collective team. Everybody pitches in here. Brad Sullivan started this along with Karen Castle, whose name should be on here. Karen's also, she's now a medical editor in the Kansas City area. And I have lots of cool collaborators on this project, and thanks to the NIH and American Heart for the continued funding. Yeah.
Jim, very nice talk and some very compelling arguments at the end. I got a question about your dabigatran data.
Yeah.
And again, I think dabigatran is a character on the Godzilla movies. When dabigatran blocks the
No, he's a transformer. Transform.
Anyway, so when dabigatran blocks the cycle of doom,
yes.
Sounds like cartoon. Do you actually see peripheral effects in those animals too? I mean, what's happening to HOMA-IR? What's happening in body weight gain? What's happening to all those other indices? Is this have a specific effect, or are you actually having beneficial effects holistically in the animal?
So that's where it gets very fun. And in the case of dabigatran, as well as other interventions that target thrombin prophylactically, we find that they're very good at inhibiting diet-induced obesity. So we see significant changes in adipose weight when we do Brucker analysis of fat mass, the body weight goes down. We see reduction in inflammation in adipose. And this is not inconsistent with data that was published by Nigel Mackman when they did bone marrow transplantation from low tissue factor mice into LDLRs. They had this reduction in body weight gain in those mice. And it just, at first it's tissue factor is driving body weight? So how can that possibly be? But then Wolfram Ruff at Scripps, in collaboration with Samaditz, Horry Pines, also did work beyond thrombin, even looking at tissue factor part 2 signaling. And they see similar things in both monocyte and adipose compartments to suggest this is the case. The hypothesis there is that this is driven through enhancement of metabolic inflammation, but how thrombin and its various targets contribute to this, we're still working on it. We don't think that the body weight is driven through PAR1, and this is why PAR1 is kind of a cleaner study. Those PAR1 null mice are almost virtually protected from fatty liver disease, but they're just as big and just as fat. So there's clearly some fun questions to try to answer. So thanks. Ken.
Jim, in addition to the PAR1, have you looked at other thrombin targets in the context of amplification of the injury response? Because thrombin is a very non-specific protease. It's going to attack pretty much any protein that has, the right combination and the right space for the, thrombin to sit in. Osteopontin is a good target of it. A lot of the integrins are targets of it. So what have you done to look into that biology?
The short answer is not enough. Clearly thrombin, I'm not sure that it's going to cleave anything, but clearly it does have a broad substrate specificity, and multiple targets are clearly of interest. We want to go beyond PAR1. We need to think about platelets in mice and think about PAR4. Osteopontin, we have thought about looking at thrombin-cleaved osteopontin in so many numerous models because clearly the cleaved form has a different integrin affinity. These are all questions that are up in the air. I have a series of collaborators at multiple institutions that have the tools to try to answer these questions. We don't know yet. The ultimate deliverable here would not be to anticoagulate people to treat obesity. While that may be interesting at the intersection of cardiology and hepatology, because people are already anticoagulated, we'd really like to understand how certain thrombin targets are driving this process to design drugs to block that without increasing the risk of bleeding. So your question, while I don't have a definitive answer for you, I can tell you all the little stuff we've done perhaps at dinner, but that's exactly what we would like to do. Yeah. Okay. Oh, Angie. So we have frozen poo. So we're doing that now. If dabigatran reduces body weight again, and this was published in JPET, we'd love to know why. So we want to know if there's differences in metabolism, absorption, secretion of fats. we're going to look, and for those that are expert in that kind of stuff, or anybody that wants to do the microbiome with us, that's outside of our wheelhouse, but we would love to look.
Yeah,
Dr. Williams.
I'm just kind of saying, people should specify what type of fat, because sometimes it's corn oil, sometimes it's soybean oil, and it makes a big difference.
Absolutely, and just to point, so the protective effects, for example, of our various mutants that we've looked at in the drugs, they seem to be consistent across multiple diets, either 40% butter, 60% lard, or the high-fat, high-carb diet that Rohit Kohli at Cincinnati has kind of championed. So we also don't see any effects on body weight gain with a control diet. So we think it's a bad, like White Castle, Mountain Dew diet, where this has an impact. But yeah, looking nutritionally at what's in the diet and how that drives the pathology, in particular if certain diet components are more likely to induce tissue factor, yeah, that's of high interest. I agree fully. Okay, I better be done.